Well, hello. Thanks very much for joining us. My name's Kath Albury. I am the lead researcher on the digital and data capabilities for sexual and reproductive health project. Just letting you know that this webinar will be recorded, and the recording will be shared with people who have subscribed for the webinar. If you would like to ask a question anonymously, feel free to directly message Sam or myself in the chat, or message the Q&A, and we can read it out anonymously for you. But when we get to the Q&A, it will also be possible for you to put your hand up, and Paul, who is our trusty event manager in the background, will be able to put your camera on and make sure that you can be seen by the other people in the event. I know these webinars are a bit strange. So yes, so that's the main housekeeping. And yeah, feel free to add questions to Q&A at any time during the webinar as well, but we will have plenty of time for questions and discussion at the very end of the event. Sam, would you mind going on to the next slide? Thank you. So I am joining you today from the lands of the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to the traditional owners and their elders, past and present. It always was and always will be Aboriginal land. I extend this respect and this acknowledgement of stolen country to all the Aboriginal and Torres Strait Islander people joining us today, and to all the First Nations people around the world who are still struggling for sovereignty. Thanks. So we are going to present today the stage 2 findings from the Australian Research Council funded project, Digital and Data Capabilities for Sexual Health Policy and Practice. And that name is steadily extending. So in fact, we're now calling it Reproductive Health Policy and Practice, but it's all a mouthful. We need to come up with a catchy acronym, and we will in due course. I'm going to tell you a little bit about the project background before we jump into the findings from stage 2. And at the very end of this webinar, we will officially launch our stage 2 project report with a little glass of tap water, as opposed to a bottle of champagne. And we will give you some information on what is happening in this project next year and how you might get involved, particularly people who are currently employed or are in leadership positions in the sexual and reproductive health sector. So although I am officially the fellow, there is a large project team involved in this work that we're presenting today. Sam Mannix, who is co-presenting with me today, is the postdoctoral researcher on the project and is an affiliate investigator at the ARC Centre of Excellence for Automated Decision Making and Society. Addie Arnott Bradshaw, Caitlin Lermouth and Xavier Mills and Joanna Williams all provided research assistance for the project. And we also had some support from Nicole Nguyen and Caleb Darwent at Transgender Victoria for the Trans-Pacific Workshop Group. I'd also like to thank Sidel Saldana, who is working with us now as we commence stage 3 of the project. And Sidel's working on the digital media component of this project. The project draws on digital and data capability models that were previously developed as part of the ADMS's activities, or Automated Decision Making at Society Centre of Excellence, I should say. You can just stay where we are, Sam. I see you trying to go back. We don't need to. And we're building on those initial models that were being developed, or were developed, I should say, in collaboration with the not-for-profit sector, to think about how digital and data capability, and I guess the capacity to really embrace digital transformation and digital innovation can be supported within the sexual and reproductive health sectors. So this is an overview of the project you're seeing on the screen right now. In the first stage, we did some interviewing with leading researchers and practitioners who were working with the concept of digital literacy in relation to sexual health. We concluded from that stage of the research that the term digital literacy was not really well understood as it related to sexual health and reproductive health. There wasn't a clear understanding of what that might be in the workforce. And we looked at a survey of literature, which kind of supported that finding. And so we moved on to this capability framework that we're presenting today to think more holistically about the role literacy might play in a larger suite of skills and resources and capacities. In this most recent stage, we worked with tech users and also health professionals aged 18 to 29. Currently, we are developing resources for the sexual and reproductive health workforce. And early next year, around about March, we will be piloting and reporting on how they actually work in the wild. Thanks, Sam. I will hand over to you to explain what we did as part of stage 2.
Thanks, Kath. So stage 2 was with a focus on young adults aged 18 to 29. We conducted workshops with about 30 people. We'll go into the details in a minute, but just to let you know that our recruitment methods up on the screen here, we recruited via organisational, so sexual health, reproductive health organisation website, social media and email lists, our own research team and the expert reference group, kind of social media networks and closed lists. And other private and closed lists on social media groups, as well as snowballing through already engaged participants. For our health professional workshops, we recruited via the project reference group and the professional networks and social media networks of our peers, and through LinkedIn, and again via snowballing. As Kath's already sort of mentioned, we also engaged with peer researchers for this work. We hired 3 peer researchers, and peer in this instance meaning between 18 and 29 years old. And they really facilitated the young adult workshops and interviews, and they participated in the design of the research, recruitment, and data analysis. As Kath also has already mentioned, we also engaged with 2 peer educators from Transgender Victoria who co-facilitated the trans-only young adult workshop, and so we had some participants who indicated a preference for a trans-only group. So that was how we engaged with them. Our workshops, for the young adult workshops, we drew upon participatory, creative and visual approaches to develop activities that kind of helped us frame questions in a way that prompted discussion between participants. For example, one of them was design an app to help health practitioners understand what kind of resources they need to engage with young people's digital cultural practices. And for our health professional workshops, we really just sort of sense checked some of the draft resources that we'd already developed based upon these initial workshops. So our young adult workshops, you can see here a bit of a demographic overview. We had a total of 32 participants across the age of 18 to 29. Our median age was 25 years old. You can see here that we mostly recruited through our recruitment methods, mostly cis women. And I think as we go through the findings a little bit today, it may sort of become clearer why this was a group that perhaps really wanted to participate in this research. Many of them shared with us, many cis women shared with us how they had used digital technologies to help manage the symptoms of endometriosis and polycystic ovary syndrome, for example, in the kind of context of not getting adequate or respectful information in other sources. So, for example, trying to get a better understanding of IUD insertion as well as IUD aftercare. And we'll talk a little bit about that later. About 2/3 of our participants were white or European, 1/3 being of South Asian or East Asian descent. We had no Aboriginal or Torres Strait Islander or other First Nations peoples. we made active efforts to kind of reach out to these networks in our recruitment, but it probably speaks to the composition of our research team being all white, and the need for a more specific and nuanced approach to these within these communities. So what did we find? You can see here on the screen an overview of some of the platforms that our participants were using to support sexual and reproductive health. You can sort of see a really diverse set of platforms and resources. Some of them are the more formal kind of avenues that you may expect, like government health websites or specific sexual and reproductive health websites, WebMD, for example. Others are kind of more diverse. We had a lot of use of menstrual trackers for our non-cis men participants, in particular, to kind of manage their symptoms of endo, whether that be trying to manage when to take pain relief or kind of being on top of their cycles, and social media platforms and other avenues like this. We also kind of really tried to unpack how and why our participants were kind of using these data-driven technologies for their sexual reproductive health. Validation was one of the most commonly kind of used terms that came up in a lot of our discussions. Participants using social media platforms to validate their experiences and concerns, particularly seeking out kind of lived experience or advice from others that have shared similar kind of symptoms or shared similar experiences with healthcare providers. We can see this really in Maddie's quote here. The amount of times I've been validated and found my experience as someone else's on TikTok. A lot of the stuff I know about endo healthcare is what I've learned from TikTok. As I said, this information did come from the sharing of lived experience through social media platforms and TikTok in particular, but also through accredited gynecologists on the platform and sexologists on the platform. So it was kind of particularly in the context of experiences with patchy or dismissive information in other areas. Young people, our participants, were seeking out different kind of different avenues of accessing this information via lived experience, via expertise. And we've sort of kind of started to frame this as a community of practice. We can also see here that young people are collecting these kind of experiences and stories and expertise as a way of taking information to clinical services, a way to help with their self-advocacy, and also using digital platforms and websites to evaluate the inclusivity of services. So whether that be looking for pride flags on a website or actually looking at the kind of inclusive language that websites or practitioners are using in their information delivery. So we also kind of asked young people what they wanted health professionals to know about their digital practices and digital sexual cultures. And they really expressed a desire for healthcare practitioners to understand and respect their digital sexual health practices. So they didn't really see these practices as being a replacement for in-person care, but as something that kind of shaped and supported their sexual and reproductive health choices, experiences, and their engagement with services. So they were aware that there could be misinformation online, but rather than having healthcare professionals dismiss that as being something that wasn't really useful, they kind of saw that as an opportunity to kind of enter into a dialogue, I guess, to sort of unpack what that information might be, but also as a way to kind of take their information seeking practices seriously, as well as their concerns. Participants didn't expect healthcare practitioners to understand the ins and outs of every single social media platform or trend. They recognized that this was probably pretty unrealistic, but it was important to recognize the ways that digital platforms and technologies did operate as I've said earlier, as sites of lived experience. So they wanted healthcare practitioners to know as we see in Jacqueline's quote here, that they weren't just getting one TikTok video and running with it, but it was a more critical and relational approach to seeking out expertise via multiple digital sources with different levels of lived experience. Our participants did have a little bit of trouble trying to imagine what kind of resources would help support healthcare practitioners to do this work. And in part, we kind of think this is largely because it is hard for a young person who is not a healthcare provider to imagine what is actually going on behind the scenes in a clinic or in a health promotion service. So to kind of unpack that a little, I'll hand back over to Kath to explain the next step.
Awesome. Thank you. Yes. So as Sam said at the beginning, we set up kind of classic co-design principles. Oh, we'll ask the young people to explain the thing. What we discovered, of course, is that when you ask people outside of a very specialized closed shop disciplinary space to imagine what people inside that space need to know, it's almost impossible for them to do so. As one participant said in a kind of slightly snarky way, like, how do I know how doctors make their decisions? They really didn't know how health professionals understood knowledge and made sense of social media, for example, and it was very hard for them to then imagine what kinds of resources might support decision-making or engagement with young people in professional spaces. We did notice, though, that we had a small subsection in that larger tech user group who were also engaged in some way in the health profession themselves, and they could very clearly articulate what they felt the leadership in health organizations or the policymakers in health organizations did and didn't know about digital platforms and technologies and what they might need to know. So we adjusted our initial planned recruitment a little bit to conduct a second round of recruitment exclusively targeting people in the sexual and reproductive health sector who were aged 18 to 29, the target age group. And I have realized that I haven't explained why we are focusing on 18 to 29-year-olds in this project. We know, or I guess people who are familiar with Commonwealth health policy and strategies would know that young people who are defined as 12 to 29-year-olds are a priority population for sexual and reproductive health kind of focus, expenditure, health promotion, clinical services, etc. They're considered to be a priority for these policies and for service provision, but most of the research and most of the resource development in this space really targets school-aged young people and school education. Once people leave school, 18 to 29, they are not really involved in research very much and are not really involved in discussions around how services might be delivered particularly, and so that's why we chose to focus on this older age group. So in our recruitment, we, as Sam said earlier, reached out through our existing networks and through our expert reference group networks, and recruited a pretty wide cross-section of people working in sexual or reproductive health. We've kept the information, the demographic information about these people very sparse in both this presentation and the report, because this is a very small part of the overall health sector, and we want to respect the confidentiality and the privacy of our participants. So this is a very high-level explanation of who was involved. Might go on to the next slide. Thanks, Sam. So we initially had asked or expected the participants in this group primarily to help us sense check our drafts of our resources, give us feedback about the frameworks and checklists that we were proposing to use as tools. But what we discovered very quickly is this group of 18 to 29-year-olds in health had some very powerful things to say about the ways that sector leadership were, I would paraphrase as under-resourcing, systematically under-resourcing digital transformation and digital innovation at the present time. So the key takeaways, aside from kind of feedback about our resource development, but the key takeaways for us from this stage were, really, as you can see here, quite, I guess, eye-opening. Sector leadership doesn't fully understand the ways that young people use digital technology and platforms for their sexual and reproductive health. So when we presented, for example, the findings from the user research, they said that really resonated with their understanding of the ways that health professionals did or didn't engage with digital technologies in their workplace. They said, as much research globally and across a range of disciplines has found, organizational approaches to digital platforms and technologies are still primarily focused on risk, which, the professionals in the workshop said was important in many cases, but not the only thing that we should be thinking about. Often digital policies were ad hoc or out of date, and this meant that organizations often missed the boat for timely digital outreach. And this was really, these two last points were, I think, the most important for any leadership or policymakers in the sector. There was a very strong kind of expression from this group that there was still not enough recognition of the dedicated resources that were needed in order to build capability in the workforce. Yes, we want digital transformation. Yes, we want innovation. That takes money and time. And there was not yet enough support for staff training, and that time and money was needed to build solid communities of practice around digital and data-based work in health. And that included kind of both engaging with social media and using new enterprise technologies, medtech style digital technologies. Finally, there was a belief, and that was supported by almost everyone in these workshops, that currently leadership in the sector is expecting young staff or youthful staff to stand in for the lack of adequate funding and infrastructure. So people said, we have digital projects, and they're just handballed to me as the young person, and I'm supposed to be the digital native. And therefore, I'm supposed to know what makes things trend on TikTok. That's not my expertise. Just because I use TikTok doesn't mean I understand digital marketing. Currently, the leadership in the organization expects me to do that just because I'm the young person. I don't have any more time in my work plan for that. My position description isn't upgraded because I'm doing this, extra project. Currently, I am really doing the work that a skilled person should be doing. And that was reported many times. And I think that's really something for the sector broadly to begin to think about in a more systematic way. And I guess the resources that we're developing as part of this project are intended to inform the kinds of conversations that might be needed in order to understand where more funding, more time, more money, different roles, for example, might need to be created or requested, what kinds of business cases might need to be made, etc. So, for example, just a selection of quotes, within my organization, digital capability building would be flipped back to me. You're the health promotion person and you know technology, you can just go and do this, because they're just incredibly time poor and I'm the young person, so I hold all the information. And the person who said this looked at our resource kit and said, look, this is all well and good, but my manager's not going to take anything on board. They're just going to say, you do this because you're the young person. Therefore, this is digital tech. Therefore, it relates to you. So I think this kind of indicated to us that there's a real need for some kind of leadership development in this space. Thanks, Sam. We might move on to the next slide. So what then are we suggesting might need to come next in order to build the kinds of capabilities that we know we need to build, both because there's kind of top-down policy saying that we need to, and also because we know that bottom-up people, health consumers, are already using digital technologies to support their health. Firstly, I'd say we need to begin to think in a more, as I said, systematic and structured ways about the different levels of existing digital and data skills, knowledge, and readiness across the sexual and reproductive health sector. It was very patchy and uneven in our interviews. Some services have very sophisticated digital strategies and digital outreach. One person that we spoke to said, look, my organization has only just given me a mobile phone. We still use paper intake forms. So the so-called, digital revolution, as we know, is very uneven. Similarly, digital inclusion is not universal among health users. So not everyone has a phone and consistent Wi-Fi access, for example, that would allow them to sign up to a kind of clinical interface using digital technology. Some people really do need pen and paper still, or face-to-face services still, and that came through very strongly in our consultation. In the resources that we are planning to build, and this was endorsed very strongly by the health professional group, we will have prompts that will help facilitate strategic conversations and dialogue, hopefully at a leadership level that should allow health organizations to engage with their community stakeholders and their consumers to help them better understand in a more holistic way, what kinds of skills and technologies are we, the health professionals, using? What kind of skills and technologies are our constituents using, or what do they need? What would they like us to use? What is easier for them to manage? What is harder for them to manage? How can they best access our services and any information or outreach we're trying to provide? And that really means there needs to be a focus on not just going for the next new fancy shiny digital tool or toy, but promoting ethical and inclusive approaches to digital transformation at every level of an organization. And of course, we need to really strongly signpost the areas of this work that require significant expertise, which might mean upskilling and training for existing workers or hiring new workers with a different skill set, and also need resource allocation in a sustained way within health organizations. So how do we build infrastructure? How do we build skills? How do we increase the capacity to work better with health consumers? This is something, as one of our participants said, doesn't just happen on the back of the young staff in an organization. It needs to be budgeted for, and there needs to be an investment of both time and money over a sustained period. Thank you, Sam. So next up, we are about to build a health resource, and what then will it look like? I've talked it all up. A number of the models that I've mentioned as part of this conversation are in the report that you'll be able to download at the end of this webinar. So you'll be able to see all the models and the checklist we've mentioned here. But what we are currently producing with the help of our digital media producer is a very simple, I guess, choose your own adventure style WordPress site that will support people who are looking to work with this model in their organizational settings. And it just includes some kind of prompts and resources to help strategic conversations. And as I said, we will pilot this at the beginning of next year. So we would love to hear from any organisations who would like us to kind of talk them through the way they might be able to use the website, and then go away and play with it and get back to us about what was and was not useful in that project, or process, I should say. The content is evidence-based. We've drawn on multidisciplinary research from my own field of media and communications and digital and data studies, but also from public health. And we have, as I've mentioned, gathered our own evidence base for this work through consultations with leaders and researchers in sexual and reproductive health, and as it relates to the domain of kind of digital and data transformation, and also from our consultations with younger people in the sexual health sector. Theoretically, we're informed by adult learning principles, so drawing on the work of people like Bell Hooks, Jack Mesereau, Stephen Brookfield. So these are not a structured curriculum with, competencies at each stage and, learning outcomes at every level, and, you work through them like a curriculum. They are intended as prompts for discussion-based learning, for critical thinking, and for building communities of practice to be tailored to the needs of an individual workplace, and drawing on existing expertise or the existing resources in situ. They are not big, any of them. They are snack-sized. One thing we were told repeatedly is that the health sector, they were pre-COVID, but post-COVID, they are really overstretched. They are under-resourced. They are overworked, and they're not reading all that. Too long didn't read is the summary version of the resources that we're offering on the website. But we will have links to relevant policy documents, to longer form academic research, and to structured university and industry-based training that does involve curriculums and formal qualifications that we are not offering as part of this project, for organisations that want to move forward from our guided discussion process into this more structured form of professional development and capacity building. Shall we hop into the next slide, Sam? Okay, so I just wanted to say, as a side note, as part of this research, one of the things, as Sam mentioned earlier on, that was really striking to us was how many people with uteruses and women responded to this call out to tell us more about how they were using digital media and digital technologies more broadly, and how many people wanted to talk about their experiences of pain, and the ways that digital technologies supported their understanding and their management of very painful chronic illness and disabling conditions. And we actually made a submission to the inquiry into women's pain, drawing on this research, and also drawing on some of the findings from another project I'm working on, which looks at LGBTQ plus people's engagement with sex tech, which is broadly, anything from a Wi-Fi powered vibrator to a dating app. And we made this submission because pain and pain management and concerns about pain and not being heard when they tried to seek healthcare came through so strongly in the data. And we will also be posting this on the website for this project for any organizations that are interested in reading more about this data. We're also happy to share. If you email us, we can share you the submission. Thanks, Sam. That was just a little sidebar, sorry. Okay, so what comes next? We will be developing the resources. They will be finished by the end of 2024. And then we'll come back in 2025, not 1925, to pilot them in March and April and do a little evaluation. And about 2/3 of the way through the year, but not clashing with any of the major conferences, that's the challenge, we will be launching the evaluated resources and sharing a range of kind of academic and sector responses to this work, or areas that research that we think dovetails well with this work. We will also, as this project is winding up, be moving into a major signature project for the ARC Centre of Excellence for Automated Decision Making and Society, which is critical capabilities for inclusive AI. Generative AI has become increasingly a topic of conversation in the field of health. And one of the things we're really interested in is, what do the capabilities that we've been talking about in our project look like in relation to the use of AI in the sexual and reproductive health sector? So we look forward to working more there, as well as with a range of other partners that you can see on the slide. There will be, the ABC is involved, Telstra is involved, a range of universities and also organisations will be involved in that project. So if you are joining us from a health organisation and you would like to participate in the pilot, we have a QR code on the screen now, but Sam will also drop the link to our EOI sheet into the chat, and we will get back to you early in the year to set a date for a pilot. Thanks. Finally, and this is where we crack the imaginary champagne or raise our glass of tap water, the report for this stage of the project is now live on the Analysis and Policy Observatory. You can see the link on the screen, and again, also a QR code. We are very grateful for all the assistance and support that we've received along the way. We've had a lot of feedback from our very active project reference group, and we're very grateful. Okay, so I think that is our last slide. Thank you very much. We will take the slides down, and now is the time for questions, conversation. I will jump into the Q&A and start that process off, but we have about 20 minutes now to answer the questions. Okay, so we have a couple of questions in the chat right now. So Daniel Readers says, I love the idea of snack-sized resources. What should the information diet of a senior manager in a sexual health org include? That is a good question. One of the things that came through in our discussion, particularly with the younger health promotion and kind of allied professionals, some of them were clinicians, I should say, some of them were policymakers and research officers. I guess if they were recommending a healthy, varied and well-rounded diet for senior managers and leaders and policymakers in the field of sexual and reproductive health, I think they would recommend more thinking about the kinds of business cases that might need to be made for really taking on digital and data-based work, and that this, in many cases, may need to go beyond kind of a project focus or a short-term focus, and also focus on, the kinds of conversations that people have in your annual professional development meeting about, what additional training would you like? What kinds of resources do we need to contribute to that training? Because many of the participants did not want to focus on digital resources just because they were young, but they felt like because they were young, they were the only person in the organization with any kind of interest or expertise there, and therefore they were forced into the role of being an expert because, they felt like, well, some input is better than nothing, but actually they would like to see these conversations formalized and resourced in a much more systematic way. The other question is the pilot open to privately held sexual health companies? It certainly could be. It's simply sharing the website and having a discussion with the staff around how relevant and useful the resources might be, and hearing how the organization might choose to use them. So definitely we're happy to hear from anyone who's interested in being part of the pilot. I'm jumping into the chat now because there's questions outside of Q&A. So I'll just see. Kathy Valet says, from your research, I'd like to know who's doing digital SRH service provision well. I'd love to see a case study. What policies do they have in place? Numbers of staff hours. That was actually not the focus of our research. So I cannot provide you, I'm afraid, with an audit of services and the ways that they are or are not using digital tools and resources and staff in place and so on. And the reason we weren't asking those kinds of questions is it's very early days. And, you know, as I said, one of the reasons that I changed the focus in this project from literacies to capabilities was we've seen in other projects that there can be a lot of shame among professionals about not being on top of data or not being on top of the latest digital technologies. And we had in our earlier projects with people who worked at not-for-profits, people were kind of saying, oh, you know, we have all this data and we collect all this data, but, you know, I don't know how to use the tech. And people were very agitated about it. And this is not intended to be a shaming exercise by any means. That we're not using the term literacy, because literacy, as we know from our colleagues in literacy studies, literacy is often used as a kind of shaming device too, like so-and-so, oh, they're digitally illiterate. So this is why we are not auditing or giving anyone report cards. That is something that other people might wish to do, but that's not the purpose of this project. Shubha Kayasa said, I was curious if the information and knowledge that young people learnt through digital media was dismissed or even discouraged by health providers. Yes, some of the people who reported going to spaces like Reddit or TikTok to better understand their experience of health conditions or other people's experiences of health conditions like ovarian cysts or wanting to understand more about IUD insertions, said they had felt dismissed or discouraged by health professionals when they tried to raise a concern. So, for example, we know, for example, that in the US, the Center for Disease Control has just recently changed the guidelines about IUD insertion to formally recommend pain management. This has been attributed in some spaces to the kind of proliferation of discourse on TikTok around painful IUD insertions. But for our participants, this was just another way of accessing lived experience or shared accounts of lived experience. And it was a way of learning about their own experience of their body and other people's bodies through what we might term a community of practice, but an informal community of practice in social media. So yes, they were not expecting that health practitioners should like TikTok, whatever liking TikTok means, but they certainly didn't want a practitioner or a health information provider to be rolling their eyes when they raised a concern based on something they had seen on TikTok. They simply wanted a kind of respectful answer to a question, whether they had the information from social media or from a formal space. Sorry, Sam has said Meredith Temple Smith has a hand raised. Sorry, the raised hand isn't showing on my screen. Meredith, did you have a question? We can pop your camera on.
No, it's all right. Thank you. I've got my response, but thank you very much.
Oh, awesome. Thank you. Thank you. Just checking the Q&A again. I'm jumping back and forth in different windows. So Denton calendar, and apologies if there's any weird background noise. My neighbor is drilling something outside my window. So for people working in resource limited settings, has our study turned up any guidance towards the top priority or highest impact for digital sexual health engagement? I would say no, because we're not actually evaluating sexual health engagement. Sorry, Denton. We actually were only trying to kind of build, I guess, a set of quasi-normative descriptions of what digital and data capability might look like. And I know this sounds a bit half-hearted when I explain it that way, but when we did our initial interviews with many leaders in the sexual and reproductive health research sector, and reviewing all of the literature we could find that talked about sexual health and digital literacy in the same article, or reproductive health and digital literacy in the same article, it became clear to us very early that while almost everyone agrees that digital literacy or digital health literacy is a good thing to have, very few people and certainly very few organizations have a working definition. And that's why we developed, drawing on those data capability models from the initial projects led by my colleague Anthony McCosker at Swinburne. We're developing these frameworks for capability so that organizations can work through those capability models and decide for themselves which elements are relevant and which elements are not relevant in their context. There is, as we speak, a separate initiative going on that the Australian Digital Health Agency is running. It's very quiet right now. It's almost been soft launched, but there is a digital workforce site that we have the link in the report, and that includes tools for auditing individual digital skills within a kind of discipline agnostic, any area of the health sector setting. So if you're a manager or if you're an individual in any health organization, you can kind of audit the way you personally are using the tools. But we have developed this kind of, I guess, organizational framework because it was very clear that these kinds of conversations need to be had across silos, and that, you know, it doesn't matter how much digital literacy an individual worker has if they don't have access to digital infrastructure, if there is a firewall in their organization, which means they can't even access social media, if the tools they have don't connect to other tools and they can't access or analyze the data their organization is collecting. You know, there are all kinds of reasons why someone with a high level of individual digital literacy might be in an organization that doesn't really support or enable their digital capability. And that's what we were really focused on kind of modeling or mapping out in the first instance. But yes, future research could certainly kind of map the sector more broadly. Abdul has asked who were our respondents. Yes, young adults 18 to 29, and also health service providers aged 18 to 29. But we previously interviewed a range of researchers and leaders in the sexual and reproductive health sector. And we basically recruited these people because somewhere in their self-description on their organizational website, they talked about digital literacy. So we wanted to get a better understanding of how they were thinking about digital literacy and what they thought it meant in their current workplace setting or context. Any other questions or responses? There's another new message popping up at the bottom. Oh, okay, that's just a thank you. So that's a lot of chat from me. Certainly, we appreciate the suggestions for other forms of research or mapping that might be undertaken in research like this. And for the researchers in the forum, we'd love to partner on that kind of research in the future. Any final kind of questions or comments that we might have before we go? No? in that case, thank you all very much for joining us. We really appreciate your questions and your input and your engagement. This has been a really interesting project for us. We've learned a lot. Sam has a public health background. I've been kind of health adjacent for a lot of my career, but never dug so deeply into the kind of nitty gritty of which elements of health systems really support digital work and which don't. So it's great for us to understand more about where future research engagement and practice might take place. So thank you. And yeah, we look forward to talking to anyone who'd like to be involved in the next stage of research. Please do reach out. All right, we'll say farewell. A short meeting's a good meeting. Thanks very much, everyone.
Thanks, everyone.